Alright, today we're going to go over Pharm exam 4 notes. I'm going to go through 4 to 6 pages. You ready? 4 to 7. Holy cow. Let's do this. Alright. So some things to remember from test 3. Morphine and heparin can be given together. The heparin is the hare. Morphine is the tortoise. Heparin, you're monitoring APTT. Warfarin, you monitor slow PT and INR, okay? So therapeutic PT, INR, and warfarin is higher than a normal PT, INR. Then you'll eventually take away the heparin because that's just a short-term therapy, okay? In general, you don't use heparin and warfarin together. However, we do give them both when they're trying to transition someone onto warfarin therapy, okay? We give heparin with the warfarin until the PT, INR becomes therapeutic. Then take them off the heparin. This is called bridge therapy. We do this with a lot of cardiac patients. Rescue inhaler for asthma is albuterol, and salmeterol is for maintenance. Theophylline is seizure precautions, but it can also cause nausea and vomiting. And then odinestrone, this helps with nausea and vomiting and headache, is a normal side effect. This is safe to take during pregnancy. All right, pain and inflammation. Let's do this. Let's do it. Let's go. Let's go. All right, morphine. How do you think we give this? PO. Immediate release or extended release. You got IV, IM, sub-Q, and intrathecally with a half-life of what? 3 hours. What is the class of morphine? It's opioid analgesic, and the therapeutic class is opioid agonist. All right. What is the Controlled Substance Act of morphine? The Schedule 2. What is the action of morphine? It affects the CNS and how you respond to pain, and it alters perception of pain. What do we use morphine for? Severe pain and MI. What are the side and adverse effects of morphine? I mean, you could have addiction, physical tolerance, and dependence. What else? Got the classic opioid triad, the coma, the respiratory depression, the pinpoint pupils. You can have urinary retention, biliary colic, emesis, orthostatic hypotension, cough suppression, euphoria, and mental clouding. So, what is the reversal agent for morphine? Naloxone. So, morphine has a big first pass effect. What does that mean? We'll take more PO than IV. Pentazocine. How do we give it? IM, IV, sub-Q, and PO is combined with naloxone. What is the therapeutic class of pentazocine? Opioid analgesic. What is the pharmacological class of pentazocine? Opioid partial agonist antagonist. What is the Controlled Substance Act of pentazocine? Schedule 4. What is the action of pentazocine? Binds to opiate receptors in CNS, alters perception of pain in the brain. What is pentazocine used for? Mild to moderate pain and managing abstinence syndrome. What are the side and adverse effects of pentazocine? So in relation to morphine, it's got minimal CNS depression, little to no euphoria, and psychomimetic effects. What do we need to know about when someone takes pentazocine? Do not take with another opioid because they will fight for receptors. This med is given to people you are trying to get off an opioid. What type of patients do we need to watch when they're taking pitazicine? Heart failure, COPD, kidney, and MI patients. All right, how do we give naloxone or Narcan? IV, IM, sub-Q, nasally, 0.4 milligrams, half-life of 2 hours. What is the therapeutic class of naloxone? Opioid analgesic. What is the pharmacologic class of naloxone? Opioid antagonist pure. What is the action of naloxone? Prevents opioid from binding to receptors, but it has a half-life of 2 hours, so you have to keep giving it if they have lots of opioids. And it doesn't produce any analgesia or any other effects caused by opioid agonists. All right, what is naloxone used for? Reversal of an opioid overdose. What are the side and adverse effects of naloxone? Abstinence syndrome, so like violent sneezing, weakness, nausea and vomiting, diarrhea, abdominal cramps, bone and muscle pain, muscle spasms, and kicking movements. What do we need to know about when someone takes naloxone? So it wears off quickly, so you have to be able to be ready to give more or be ready to hold them down. And you give this to newborns too if their mothers have been using opioids as well. All right, Tramadol. How do we administer Tramadol? PO, immediately or extended release. What is the therapeutic class of Tramadol? Non-opioid, centrally acting analgesic. What is the Controlled Substance Act of Tramadol? Schedule 4. What is the action of Tramadol? Combinations of opioid and non-opioid mechanisms, weak agonist activity mu receptors, blocks uptake of NE and serotonin, activates monoaminergic spinal inhibition of pain. What is Tramadol used for? Moderate to moderately severe pain. What are the side and adverse effects of Tramadol? Severe side effects, which are rare: sedation, dizziness, headache, dry mouth, constipation, get CNS and respiratory depression. And then drug concomitant CNS depressants increase effects, and MAOIs cause hypertensive crisis, and you can have constipation. All right. What do we need to know about when someone takes Tramadol? Can be a vehicle for suicide. All right, aspirin. How do we give aspirin? PO and PR rectally if unresponsive. What is the therapeutic class of aspirin? COX-1 inhibitor, antiplatelet, non-narcotic analgesic, antipyretic, anti-inflammatory, antiplatelet. What is the action of aspirin? Helps prevent platelet aggregation and activates COX-1. What is aspirin used for? Inflammation, pain, MI, stroke, and fever. What are the side and adverse effects of aspirin? Rise syndrome, so like a viral illness with a heartburn, and then nausea and heartburn as well. All right, what do we know about aspirin when it comes to pregnancy? It's a pregnancy category D drug, so don't take it. What do you know about aspirin when it comes to kids? We got to educate their parents about aspirin because Pepto-Bismol contains aspirin. What are we going to monitor when someone is taking aspirin? So we'll monitor like bleeding, so like blood and emesis in the stool, platelet counts, low blood pressure, high heart rate, and then like the renal function, so be it bun and creatinine and GI upset. All right, ibuprofen, aka Advil and Motrin. How do we give ibuprofen? PO. What is the therapeutic class of ibuprofen? Non-aspirin, first gen NSAID. What is the action of ibuprofen? Inhibits COX-1 and COX-2. What is ibuprofen used for? RA and arthritis. What are the side and adverse effects of ibuprofen? GI bleeding and then Stevens-Johnson syndrome, but this is usually very well tolerated. What do we need to know about when someone takes ibuprofen? You need to take this with PPIs, and you need to watch for MIs and strokes when someone takes ibuprofen. All right, Celecoxib. What is the therapeutic class of Celecoxib? Non-aspirin, second gen, COX-2 inhibitor NSAID. What is the action of Celecoxib? Prevents prostaglandin synthesis by inhibiting COX-2. What is Celecoxib used for? Osteoarthritis, RA, and pain. What are the side and adverse effects of Celecoxib? Ulceration, CV effects, renal impairment, and sulfur allergy. What should we take Celecoxib with? PPI. And what drugs may Celecoxib interact with? Warfarin, so monitor the PT. And what else do you think we should know about when taking Celecoxib? Bleeding, allergies, cardiovascular, and renal stuff. All right, acetaminophen. What is the class of acetaminophen? Second gen NSAID COX-2 inhibitor. What is the action of acetaminophen? Inhibits COX-2. No anti-inflammatory response, just helps with pain. What is acetaminophen used for? Post-op pain and fever. What are the side and adverse effects of acetaminophen? So it's very toxic to the liver, and you could have like hepatic necrosis, so like nausea, vomiting, diarrhea, sweating, and abdominal discomfort. What is the antidote for acetaminophen? Acetylcysteine, but you gotta watch for sulfa allergies. What else do we need to know about when someone takes acetaminophen? Gotta watch the liver enzymes, monitor alcohol intake because it's hard on the liver, can be a vehicle for suicide, and it's safer for children with viral illnesses than ibuprofen because of the Rise syndrome. All right, glucocorticoids, the prednisone, dexamethasone. How do we give those? PO, IM, IV, topical, inhalation, intranasal injection. What is the action of the glucocorticoids? Decrease the inflammatory response of the body. What are the glucocorticoids used for? Non-endocrine disorders, RA, SLE, COPD, asthma, neoplasms. What are the side and adverse effects of the glucocorticoids? Adrenal insufficiency, osteoporosis, infection, glucose intolerance, fluid and electrolyte imbalance, growth delay, peptic ulcer disease, Cushing syndrome, weight gain, and immunosuppression. What do we need to know about when taking the glucocorticoids? Don't discontinue abruptly because you could get Addison's. And then you want to check for bloody stools, monitor glucose, watch for H&H, electrolytes, and coffee ground emesis. All right, how do we give methotrexate? PO, what is the therapeutic class of methotrexate? Antineoplastic. What is the pharmacologic class of methotrexate? Anti-metabolite. What is the action of methotrexate? For RA, it has an anti-inflammatory action and it suppresses your own immune response. What do we use methotrexate for? RA, cancer, and lupus. What are the side and adverse effects of methotrexate? Enteric enteritis, GI perforation, respiratory problems, pulmonary fibrosis, and mouth ulcers. What do we need to know about when taking methotrexate? Administer it 1 time per week, monitor stools and blood, breathing and baseline chest x-ray, immune system, and liver and kidney function test. What do we know about methotrexate when it comes to pregnancy? The pregnancy category X drug. What do we know about methotrexate and folic acid? You're going to give it with folic acid to prevent complications, but take those 24 hours apart to help with absorption. All right, allopurinol. How do we administer allopurinol? PO or IV? What is the therapeutic class of allopurinol? Xanthine oxidase inhibitors. What is the action of allopurinol? Decreases uric acid levels in the blood, so less than 6 in females, less than 7 in males. What is allopurinol used for? Gout and hyperuricemia. What are the side and adverse effects of allopurinol? So like hypersensitivity syndrome, so like rash, fever, eosinophilia, dysfunction of the liver and kidneys. You can also have GI upset. And if you take it longer than 3 years, you could get cataracts. So what are we going to take allopurinol with? You're going to take it with a full glass of water and drink at least 8-ounce glasses of water per day because kidney stones can develop. And if you have GI problems, take it with food. What are we going to monitor when someone's on allopurinol? Liver and kidney function. All right, patient-controlled analgesia. It's used for pain control after procedures, palliative care, and trauma. Patient-controlled analgesia, you need a physician's order. You have to watch for sedation. You got to watch blood pressure, monitor vitals, check the pain levels every 2 to 4 hours when they say they have pain. You want a patient who's aware and alert when teaching them. Make sure your family members don't push the button. What is a COX-1 inhibitor? It's enzyme responsible for inflammation, prostaglandins that promote platelet aggregation and promote the stomach and intestinal lining. What is a COX-2 inhibitor? Produced at the site of tissue inflammation causes fever. So some key takeaways of this. Everything affects the liver and kidneys, so monitor lab. All NSAIDs are not the same. Make sure your patients are educated on their meds. Make sure patients are aware of naloxone in case of overdose. Multiple other ways of pain relief prior to opioids. You also have non-pharm therapy things. There's alternate meds for therapies like Ibuprofen and Tylenol. Only the patient can use the patient-controlled analgesia. And be aware of patients that have depression and suicidal thoughts. What is the common organ toxicity associated with medications used to treat TB? Liver toxicity. What are the 2 teaching points that should be provided for the individual who will be taking medications to treat TB? Don't skip doses, take all your meds. Why is more than one drug used to combat TB? Lowers the risk of a drug not working due to a mutation and reduces the incidence of relapse. Beyond the risk to the individual who is being treated for active TB, what greater risk might you associate with the infection? Latent TB, reactivation of TB, and spread of infection throughout the body. Amphotericin B is used to treat serious systemic fungal infections or common topical fungal infections. Systemic fungal infections. Name 2 patient concepts that amphotericin B could affect. Infusion reactions and nephrotoxicity. Itraconazole is used to treat which type of infections most commonly? Fungal pathogens, candidiasis, and superficial mycoses. Acyclovir is used to treat which type of infections most commonly? Herpes simplex virus and varicella zoster virus. A patient comes to the clinic with flu symptoms. He has been feeling sick for the last 24 hours. What treatments may be prescribed? Also Tamiflu and Tamiflu. Name 1 contraindication to flu vaccination. Moderate to severe fever, hypersensitivity to eggs. Okay, reviewing the last 10 slides. Can give warfarin and heparin together. The hare is heparin and the tortoise is warfarin. With heparin, you monitor APTT. With warfarin, you monitor slow PT and INR. Therapeutic PT INR on warfarin is higher than a normal PT INR. Eventually, you take away the heparin because that is just a short-term therapy. In general, you don't use heparin and warfarin together. However, we do give them both when we're trying to transition someone onto warfarin therapy. We give heparin with the warfarin until the PT INR becomes therapeutic, then take the client off the heparin. This is called bridge therapy, and we do it a lot with cardiac patients. Rescue inhaler for asthma is albuterol, and salmeterol is maintenance. Theophylline is seizure precautions, but it can also cause nausea and vomiting. Ondansetron helps with nausea, vomiting, and headache as a normal side effect. This is safe to take during pregnancy. Morphine, we give it PO, immediate or extended release, IV, IM, sub-Q, intrathecally with a half-life of 3 hours. Its therapeutic class is opioid analgesic. Pharmacologic class is opioid agonist. It's a Schedule 2. Morphine's action affects the CNS and how you respond to pain. It alters perception of pain. Morphine is used for severe pain and MI. Adverse effects of morphine could be classic opioid triads of the coma, respiratory depression, and pinpoint pupils, urinary retention, biliary colic, emesis, orthostatic hypotension, cough suppression, euphoria, and mental clouding. The reversal agent for morphine is naloxone, and morphine has a big first pass effect, so you're going to take more PO than IV med. You administer pentazocine, IM, IV, or sub-Q, and with PO, you combine it with naloxone. Its therapeutic class is an opioid analgesic, and its pharmacologic class is an opioid partial antagonist, and it's a Schedule 4. The action of pentazocine is to bind to opiate receptors in the CNS and alter the perception of pain in the brain. Pentazocine is used for mild to moderate pain and managing abstinence syndrome. The side and adverse effects of pentazocine are kind of like morphine, but you have minimal CNS depression and little to no euphoria and psychomimetic effects. With pentazocine, don't take with another opioid because they will fight for the receptors. This med is given to people you are trying to get off an opioid, and you want to watch heart failure patients, COPD, kidney patients, and MI patients. With naloxone or Narcan, give it IV, IM, sub-Q, nasally, 0.4 milligrams, half-life of 2 hours. Naloxone's therapeutic class is opioid analgesic, and naloxone's pharmacologic class is opioid antagonist pure. Naloxone's action is to prevent opioid from binding to receptors, but it has a half-life of 2 hours, so you have to keep giving it if they have lots of opioids. It also doesn't produce analgesia or any of the other effects caused by opioid agonists. Naloxone is used to reverse opioid overdose, and the side and adverse effects you may see with naloxone is abstinence syndrome. So you can have violent sneezing, weakness, nausea, vomiting, diarrhea, abdominal cramps, bone pain, muscle spasms, and kicking movements. Some things you need to know when taking naloxone, it wears off quickly, so you have to be ready to give more naloxone. If you see signs of opioids kicking back in, get ready to give more. We said that. You want to watch for sedation and respiratory depression with naloxone. And then newborns can be given Narcan if their mothers have been overusing opioids. With Tramadol, we give this orally, extended or immediate release. Tramadol's therapeutic class is non-opioid essentially acting analgesic, and it's a Schedule 4 drug. The action of Tramadol is it's a combination of opioid and non-opioid mechanisms. Weak agonist antagonist mu receptors block uptake of NE and serotonin. They activate monoaminergic spinal inhibition of pain. Tramadol is used for moderate to moderately severe pain. Side and adverse effects of Tramadol could be severe, potential, but these are rare, like sedation, dizziness, headache, dry mouth, constipation. You also have CNS, respiratory depression. And then if you take concomitant CNS depressants, these increase the effects. And MAOIs, you could have hypersensitivity crisis, and you can have constipation. With Tramadol, this could be a vehicle for suicide. You give it aspirin, PO or PR if unresponsive. Aspirin is a COX-1 inhibitor, antiplatelet. It's a non-narcotic, analgesic, antipyretic, anti-inflammatory, and antiplatelet. The action of aspirin is to help prevent platelet aggregation. It also inactivates COX-1. Aspirin is used for inflammation, pain, MI, stroke, and fever. Side and adverse effects of aspirin are Reye's syndrome, heartburn, and nausea. With aspirin, it's a pregnancy D category. You want to educate patients about giving it to kids because Pepto-Bismol has aspirin. And you want to monitor bleeding, renal function, and GI upset. Ibuprofen, aka Advil and Motrin, take this orally. Ibuprofen's class is a non-aspirin first generation NSAID. The action of ibuprofen is to inhibit COX-1 and COX-2. Ibuprofen is used for RA and arthritis. Side and adverse effects of ibuprofen could be Stevens-Johnson syndrome, but this is usually relatively tolerated, and GI bleeding. Ibuprofen, you want to look for MIs and strokes, and you may take with PPI to protect the stomach lining. Celecoxib is a non-aspirin second-gen COX-2 inhibitor NSAID. Celecoxib inhibits COX-2 and prevents prostaglandin synthesis by inhibiting COX-2. You take celecoxib for osteoarthritis, RA, and pain. Celecoxib may cause ulcerations, CV effects, renal impairment, and this affects people with sulfa allergies. So you want to look for bleeding, allergies, look at cardiovascular function, renal function. Celecoxib may interact with warfarin, so monitor PT, and you want to give this with PPI to decrease GI effects. Acetaminophen is a second-gen NSAID COX-2 inhibitor. It inhibits COX-2, and there's no anti-inflammatory response, just helps with pain. Acetaminophen is used for post-op pain and fever. It's very toxic to the liver, so you could have hepatic necrosis, such as like nausea and vomiting, diarrhea, sweating, and abdominal discomfort. So acetaminophen, you want to watch liver enzymes. You want to monitor alcohol intake. The antidote is acetylcysteine, but you want to watch for sulfa allergies, and can be a vehicle for suicide and is safer than ibuprofen. All right, prednisone, dexamethasone are the glucocorticoids. Give us PO, IM, IV, sub-Q, topical, inhalation, intranasally, injection. Glucocorticoids decrease the inflammatory response in the body. The glucocorticoids are used for non-endocrine disorders, RA, SLE, COPD, asthma, and neoplasms. Glucocorticoids may cause adrenal insufficiency, osteoporosis, infection, glucose intolerance, fluid and electrolyte imbalance, growth delay, peptic ulcer disease, Cushing syndrome, weight gain, and immunosuppression. Glucocorticoids, you want to check for bloody stools, monitor glucose, watch for H&H, electrolytes, and coffee ground emesis. And you don't want to discontinue glucocorticoids abruptly or at risk for Addison's disease because you're not making enough corticoids. Methotrexate, you give it orally. Therapeutic class of methotrexate is anti-neoplastic. Pharmacologic class is anti-metabolite. With methotrexate for RA, it has an inflammatory action and it suppresses your own immune response. Methotrexate is used for RA, cancer, and lupus, and methotrexate potentially causes intrahepatic hemorrhagitis, GI perforation, respiratory problems, pulmonary fibrosis, and mouth ulcers. With methotrexate, you give it once a week. You want to monitor stools for blood. You want to look at breathing and baseline chest X-ray, immune system, liver and kidney functions test. It's a pregnancy category X drug, and you want to give methotrexate with folic acid to prevent complications, and you want to take these two 24 hours apart to help with absorption. Allopurinol, you give it PO or IV. Allopurinol is a xanthine oxidase inhibitor. Its action is to decrease uric acid levels in the blood, less than 6 in females, less than 7 in males. Allopurinol is used for gout and hyperuricemia, and allopurinol may cause hypersensitivity syndrome in the form of rash, fever, eosinophilia, and liver dysfunction and kidney dysfunction. It can also cause GI upset, and if taken more than 3 years, maybe cataracts. Allopurinol, take with a full glass of water and drink at least 8-ounce glasses of water per day because kidney stones can develop, and take with food if they have GI upset, and you want to monitor the liver and kidney function. Patient-controlled analgesia. This is used for pain control after procedures, palliative care, and trauma. It needs a physician's order. You want to watch for sedation, watch blood pressure, monitor vitals, check pain levels every 2 to 4 hours when they say they have pain. Patient control only, so make sure they're paying attention, and make sure family members aren't pushing the button. COX-1 inhibitor is an enzyme responsible for inflammation. These are prostaglandins that promote platelet aggregation and protect the stomach and intestinal lining. COX-2 inhibitors are produced at sites of inflammation and they cause fever. Key takeaways from this: everything affects the liver and kidneys, so monitor labs. All NSAIDs are not the same. Make sure your patients are educated on their meds. Make sure patients are aware of naloxone in case of overdose. Multiple other ways of pain relief prior to opioids, non-pharm therapy things, alternate meds for therapy. Only patient can use PCA. Be aware of patients that have depression and suicidal thoughts. Liver organ toxicity is associated with meds used to treat TB. 2 important teaching points that should be provided for the individuals who will be taking meds to treat TB. Don't skip doses and take all your meds. Why is more than one drug used to combat TB? It lowers the risk of a drug not working due to a mutation and reduces the incidence of relapse. Beyond the risk of the individual who is being treated for TB, active TB, what greater risk might you associate with infection, latent TB, reactivation of TB, or spread of infection throughout the body? Amphotericin B is used to treat serious systemic fungal infections or common topical fungal infections. Systemic fungal infections. Name 2 patient concepts that amphotericin B could affect: fusion reactions and nephrotoxicity. Itraconazole is used to treat which type of infections most commonly? Fungal infections, candidiasis, and superficial mycoses. Cyclovir is used to treat which type of infections most commonly? Herpes simplex virus and varicella zoster virus. A patient comes to the clinic with flu symptoms, has been feeling sick for the last 24 hours. What may we give them? Oseltamivir and Tamiflu. Name one contraindication to flu vaccines. Moderate to severe fever, hypersensitivity to eggs.
Okay. I'm going to close stuff as I go so my computer doesn't keep being so slow. I guess it doesn't help that I have 5,000 things open. Okay, spices. I know you guys know spices. I'm not going to beat spices into you again, right? But Jerry syndromes, sleep disturbances, problems with eating or feeding, incontinence, confusion, evidence of fall, skin breakdown. That's what that tool is looking at. Okay, and then our Lawton, the IADL versus the CATS, right? So the Lawton IADL is looking at those independent activities of daily living. So can this person live in a house by themselves? And are they able to perform those functions, right? Like using the phone, and washing their clothes, and getting their own food, and making their own food, and going back and forth to the stores and stuff. So that's what the Lawton is looking at. And you can see on this, if it's pulled up, it doesn't give you like a final score, but each category gives a high functional score, right? So if they can do any of the things that helps them maintain that activity, then they get a 1. But if they're completely incapable of doing it, then they get a 0. And then you guys know the CATS is the ADLs, right? So I think of ADLs as anything that you have to do in the bathroom plus feeding yourself is basically ADLs, right? Slow. So bathing, dressing, toileting, transfer, incontinence, and feeding. That's what we're looking at. And you guys know this one does have a total score point on it. They're very independent. The higher the score, the lower the score, the less dependent they are. I mean, less independent they are, sorry. Okay, the last thing that